Okay, we'll get started. Okay, so cardio is done. There was one give back. There was a question about carbonic anhydrase, but I didn't really go over very well. So I gave that one back. Everything else was fine. So if your grade went up by 2, it's because of that carbonic anhydrase question. Otherwise, everything else is set. So for that exam. If you didn't do as well on the cardio as you wanted, don't worry, you'll get it again. We repeat a lot of things over, you get more pathophys. It'll come back. It'll make sense eventually. This next unit is urinary and GI system. Very juvenile, just all about pee and poop. That's how we make it. That's all we're learning about. The next 2 sections is just that. The material, like I said this morning, after renal, because we do a lot of the acid-base stuff, which we'll do on Thursday, so you get a good review for PAs for your clin lab exam on Friday. So we'll do a lot of acid-base stuff on Thursday. Everything else we're going to learn today about the kidney system, how we filter, what are we filtering, why does it filter certain things. The key thing to keep in mind when it comes to the renal system, the body does not care about the concentration of the urine. It doesn't matter. Urinary components, what's in the urine, it doesn't matter. What matters is what's in the extracellular fluid volume. That's what the kidney is going to be looking at. These are your objectives for today. Little meme to start you off. Get you going. Okay. So like I said, the ECF is the very, very important thing that the renal system is looking to maintain. So cardiovascular was cardiac output. Pulmonary system was O2 content in the blood. Renal system is management of the extracellular fluid. Okay. Also important for BP control because we can alter our extracellular fluid volume. If we get rid of a lot of water weight and we diurese ourselves, we're losing water volume, what happens to our pressure in the system? Decreases. There's less volume of blood pressure comes down. That's how the kidneys can regulate blood pressure. If our blood pressure is too low, the kidneys will sense this, kick in some hormones to bring your blood pressure back up again by altering how much water we lose in our urine. So that's what the kidneys are mainly dealing with. And obviously, our ions, potassium, magnesium, calcium, we're to go through how the renal system handles this, as well as sodium. And when we talk about sodium, we're going to talk about diuretics and how diuretics work and where they work. The structure is the nephron. That is the structural unit. There are between 500 and 800,000 nephrons in every kidney. So each kidney has a whole bunch of these nephrons. But we're going to talk about one nephron, and it's the same for all the nephrons in the whole kidney. Each of them do the same thing. They have functionally and histologically distinct segments. So we're going to learn about the structure of the nephron, and you're going to be responsible for knowing at each part of the nephron what is going on. So this is what the nephron essentially looks like. When we draw it out, we are going to pull out the Bowman's capsule to make it one long line. But just realize that this Bowman's capsule does ride right along that macula densa. The macula densa is very important because it's going to sense blood volume. So that's where blood volume is being sensed by the kidneys in the macula densa, which is actually in the distal tubule, but it's right next to the glomerular capillaries, so it can figure it out. So that is one thing that we're going to talk about. The Bowman's capsule is the first one. The second one we're going to talk about is the proximal tubule. After the proximal tubule, we have our loop of Henle, which consists of 3 parts: a thin descending limb, a thin ascending limb, and a thick ascending limb. So these are the structures of the kidney. As you come up through that loop of Henle, we then enter the distal tubule. And then the distal tubule is going to drain into these cortical collecting ducts. And these cortical collecting ducts basically just capture all the urine formation. And where's all these cortical collecting ducts going to end up? Eventually, in the bladder. They all drain to get into the bladder. And the other thing, we talked about that already. Now, we're going to talk about the type of nephrons. There are two different types of nephrons, and it depends on how deep they go into the medulla. The majority of them, 85%, are going to be these cortical nephrons. And let me pull this picture up. So this is the cortical nephron. If you see this line right there that I drew in, that separates the cortex of the renal system versus the medulla of the kidney as well. Cortical nephrons, which are 85% of all nephrons, just hang out in the cortex. They don't go very deep. The remaining ones are these juxtamedullary nephrons, and they go all the way into the medulla. And you can see that it also has this structure called the vasa recta, which is a bunch of arteries or capillaries, essentially all capillaries, that surround the entire loop of Henle as it goes into the medulla. This is important when we have episodes of hypovolemia, low blood volume. These nephrons can hold on to some blood and kind of, in a way, stave off hypovolemia when we have low blood volume. So that's the role of those juxtamedullary nephrons. Important for urine concentration. They're salt conserving. And then here's the part right here. When effective circulating blood volume is low, that was a question on the exam, wasn't it? Okay. So let's think about this for a second on that question if you got it wrong. The question was talking about volume of blood. That's it. 3 of those 4 choices had the word baroreceptor in there. What's a baroreceptor measuring? That can't be the answer, right? It's the only one that wasn't, which is the juxtamedullary nephron, which we did mention in class. So that was the answer, this juxtamedullary nephron, but all the other ones were measuring pressure. They weren't measuring anything about volume. These ones actually measure effective circulating volume. Okay. So, general principles of urine formation. We are going to be talking about glomerular filtration a lot. GFR, glomerular filtration rate. Okay, our kidneys will filter about 150 to 200 liters of plasma a day. And of that 150 to 200 liters of plasma a day, you'll make like 2 liters of urine that you eventually will void throughout the day. So we do reabsorb a ton of the fluid, bring it back in. When GFR starts to drop, then you start worrying about renal insufficiency. The magic number to remember is 60. If your GFR is below 60, you've got some kidney problems. What's the other value that we look at to assess our kidney function? BUN and is it really creatinine? What is it really? Creatinine clearance. We're looking at the clearance of creatinine when we look at that value. So it looks at kidney function, how much, we're talking about clearance later on today, but you're going to see where that number comes into play, the creatinine, when we get there. Of the GFR versus the BUN and creatinine levels, the GFR is a better, more sensitive indicator for kidney function. I like to use GFR a lot more. We'll explain more when we get to creatinine later on, but GFR is one of the best ones to look at. Now, like I said before, 98 to 99% of the filtrate is put back into the blood. We mentioned before there's like 200 liters of plasma that's filtered by the kidneys every day. 98, 99% of that comes back into the blood. So we're not really losing blood volume. We're maintaining a normal blood volume that our body needs. If we have too much, then our kidneys will get rid of it and you pee it out. So we have to know some definitions here. When we talk about filtration, filtration only occurs in the Bowman's capsule. That is the only time you have filtration. It occurs in the Bowman's capsule. So if you look at the black line that's going through the red, you see some of it left the capillary and it got dumped into the Bowman's capsule. That is going to be filtered. So that's the first word, filtration. We're dumping the contents, from our plasma into the Bowman's capsule to be filtered. We also have filtration with partial reabsorption. When we reabsorb something, we're pulling it back into the bloodstream. So at first we dumped in a bunch of sodium into the filtrate, into the Bowman's capsule. We want to reabsorb that sodium. You don't want it to go away. So we reabsorb it to pull it back in. Same thing with water. We're going to reabsorb the water back in. Why is this called reabsorption and not absorption to begin with? Where does absorption occur? GI tract. The first time we absorb something, it's in the GI tract. Everything outside of that is a reabsorption of something. So we're reabsorbing it, pulling it back into the bloodstream, and this happens at places outside the Bowman's capsule. It could be in the distal tubule, the proximal tubule, loop of Henle. But if you're taking a solute out of the urine, out of the tubular lumens, pulling it back into the bloodstream, it's considered reabsorption. This C is just talking about complete reabsorption. So we filter it, but we take all of it back out, and none of it gets to the urine. That is complete reabsorption. You can't detect this at all in the urine, which means our body has completely reabsorbed it. It doesn't get filtered out. The last one is filtration and secretion. A secretion is when you dump any solute into the lumen beyond the Bowman's capsule. If you dump solute into the Bowman's capsule, that's called filtration. If you're dumping solutes into the tubular lumen outside the Bowman's capsule, distal, proximal, loop of Henle, that's considered secretion. We are secreting that substance back into the tubular lumen to form urine later on. That's called secretion. So make sure you understand filtration, reabsorption, and secretion. Yes?
Is the red?
The red is the capillary.
The capillary?
Yep, or the blood.
And the yellow is?
The tubular is the lumen that's going to form the urine. So anything that goes into that yellow is going to form the urine. If it comes back out, it's going to leave the urine formation. It's going to be reabsorbed into our bloodstream. So make sure you understand those definitions as well. So in this picture, what we did was we just took out that Bowman's capsule and we flattened it out. So now it's one long nephron, and we're going to go over the top section and the middle one. So basically, this is an overview of everything that we're going to learn about in this section. So the first section, I'll do different colors. The first one is the Bowman's capsule. And this is where filtration occurs. The next section proximal tubule is the next section we're going to talk about. And we get some reabsorption and secretion happens at this stage as well. The next phase, the next stage in this whole apparatus is the loop of Henle. Loop of Henle is very important in diluting or concentrating the urine. So if we're worrying about dilution or concentration of the urine, what do you think is going to be moving in the loop of Henle? What? Water. And what else? Salt. Sodium chloride. Wherever sodium goes, usually water is going to go along with it. Okay? If you eat very, very salty food, you get very thirsty. And you start drinking a lot of water and you get swollen because wherever the salt goes, water is going to go with it. So loop of Henle, dilution and concentration of the urine. The last section is the proximal or distal tubule. And the real important thing to know about the distal tubule is it's under hormonal control. If you think about the nephron as one big glass, and let's say I told you, okay, you have a 1 liter, I'll just use this as an example, since I can see through it. So we have this bottle of water. I told you, okay, this bottle is empty. I want you to fill the water bottle to the very, very top of the opening. How would you pour the water in at first? Would you go very, very, very slow at first, or would you go very fast and then slowly, we get towards the end, then you slowly titrate it? You would do it that way, right? Full on blast at first, then slowly go from there. The kidneys work the same way. The majority of all the filtration has the majority of all the solute in it. But as we get to the distal tubule right at the end, we have hormonal control, mainly with aldosterone, to alter that last little bit of urine concentration. It's under hormonal control. Fine-tuning of the concentration happens at the very, very end. Okay? And then finally at the end, we have our distal convoluted tubule, I'll put it DCT, distal convoluted tubule, or common collecting duct. Those are two ways of describing that last little bit. But remember, other nephrons are feeding in to that cortical collecting duct. So it looks like just one, but there really is a bunch going on. Usually there's 6 nephrons attached to one common collecting duct, and then all those common collecting ducts will combine to those into the renal pelvis and collect all that the ureter, and eventually goes into the bladder and from there. On the bottom part, let's talk about what is actually being secreted, filtered, or reabsorbed. So the first thing is going to be first section, Bowman's capsule, ions, and water, and nutrients are all dumped into the filtrate, into the Bowman's capsule. When we get to the distal convoluted tubule, proximal tubule, we're going to reabsorb. So the blue arrow is leaving the lumen, so we're reabsorbing it. And it's going to be sodium, potassium, nutrients, and water. So we're going to reabsorb these things. We don't want our nutrients going into our urine. We're going to talk about glucose in a little bit and where that goes into the urine. Why do we get glucose in the urine? It shouldn't be there, but diabetics have very sugary urine because they have too much blood sugar going on. At this level, we are also going to secrete hydrogen. So we're going to put hydrogen ions into the urine. What is that going to do to the urine? Acidify it or alkaline it? Acidify the urine. If we're acidifying the urine, where is this acid not going to be? In the blood. So you see how metabolic compensation starts taking effect now. We can alter the hydrogens in our urine to alter the pH in the blood. Again, we don't care about the concentration, the pH of the urine. It's a waste product. We use it as a tool to measure what's going on in the body, but again, we don't care about the concentration of the urine. As we get to the loop of Henle, the loop of Henle is concentration of water and the urine. So at this point, we can possibly reabsorb more water if we need to. And on the ascending thick loop of Henle, this is going to be our sodium and our chloride. We're talking about concentration of the urine, how much water is going to be there. So obviously water is the one that's got to have to move in and out, or salt is going to have to move in and out to help concentrate or dilute out the urine. Yes?
It's showing that the sodium and chloride are being reabsorbed?
Yes, we're pulling them out. So if I pull out the water from the urine to put back into the blood, what's going to happen to my urine concentration? More concentrated or more dilute? More concentrated. I'm pulling out the urine. Okay, think about, you've all heard this thing, what's the color of your pee tell you? So if it's white, clear, that means that you're pretty well hydrated, you're peeing a lot of water. But if it's dark in color, there's a lot of solutes in there that give it that yellowish color. It's the urea that's in there and other things that give it that yellowish color. If it's very, very yellow, it's a very concentrated urine because all that water you're pulling back in to maintain your extracellular fluid volume. So we're pulling that water back into our blood, concentrating the urine, and it turns yellow. If we have too much water or too much blood volume, then we get rid of that urine, get rid of that extra plasma by filtering out the water and leaving it in the tubular lumen. It stays there, and it goes and it forms urine. And now you get clear urine because you're keeping all that water in it because you don't need to pull it back. So always go back to that extracellular fluid volume. That's what we're trying to maintain. Now, as we move along, now we're in the distal tubules. At the distal tubule, we're going to, again, reabsorb sodium and water. And also, at this point, we can filter, if we need to, secrete hydrogen and potassium. If we need to. So all of these things are if we need to. This is what's going to happen. But this is where it happens. Then finally we get to that distal, the common collecting duct, the cortical at the end there. And at this point, we can pull out more sodium and water. And then at the very end here, we have a bidirectional arrow. And the bidirectional arrow is very important, and it has to do with hydrogen and potassium. Because I said this last little bit is under fine hormonal control, do you remember how much we talked about potassium being so tightly regulated in the ECF? Why is it so important to keep potassium at a regular level? What does it do when your potassium goes real high? It doesn't stop the heart. Yes, it will. That's why they kill people. But lethal injection, they give you potassium. It stops the heart in high doses, not little doses. Remember, it raises the threshold, or it raises the resting membrane potential. It makes it closer to threshold so you can get more lethal heart rhythms. We need to control potassium. So at that last little bit here, where it's under hormonal control, when we get to potassium regulation later on, you'll see how this thing can be altered depending on what we need in the ECF for our potassium levels. So it's bidirectional, but we don't know what's going to happen until we actually get our values and we see what we need to do. So this is a summary of each phase as you go along the nephron. What's being absorbed, what's being secreted, what's being filtered, reabsorbed. The rest of the chapter is kind of going through each phase and looking at different ions, sodium by itself, look at potassium by itself, magnesium, and the other ones, kind of see how we regulate those. So this is like a summary slide, kind of gives you the idea of what we're going to be doing the rest of the time. Okay. The next thing we have to talk about, we did the nephron. Now let's talk about the blood flow going to our kidneys. Okay, renal blood flow, RBF. It's not the resting B phase, but it's still RBF. Normally, our kidneys get about a quarter of our cardiac output. What's a normal cardiac output? 5 liters, so about 1.25 liters per minute. It's going to go to the kidneys. The high rate of renal blood flow to supply enough plasma for glomerular filtration. If renal blood flow goes up, more blood is going to the kidneys, which means more plasma is going to the kidneys, which means more filtration is going to happen. So if renal blood flow goes up, GFR is going to go up as well. If renal blood flow goes down, there's less plasma coming to the kidney. Therefore, GFR is also going to come down. Bless you. Everyone good with that concept? Renal blood flow to GFR. So renal blood flow is auto-regulated. What does that mean? We learned about that in cardiovascular. It's going to maintain a constant blood flow across a wide range of MAP. What other system has auto-regulation besides the kidney? The brain. Very good. We can alter renal blood flow through sympathetic vasoconstriction. What neurotransmitter is going to do that? What neurotransmitter? Not the receptor, we're not there yet. Norepinephrine. Why is it norepinephrine? They have a high affinity for those alpha-1 receptors. Alpha-1 receptors are in the vasculature. So norepinephrine can alter the renal blood flow, shunting the blood away from the kidneys to other places that we need more blood. Okay, all blood enters the kidney, passes through larger branches to reach these glomerular capillaries. So we have a couple of capillaries we have to talk about. The glomerular capillary bed, this is all those little bundle of capillaries inside the Bowman's capsule. So inside that Bowman's capsule, remember it's like a little U-shaped, a Y-shaped thing. The blood, when it comes in, does all weird things inside and then it comes out. This is the afferent capillary. This is the efferent. Okay, it's drained via an efferent arteriole instead of a venule. Why? Because this efferent arteriole is then going to go to the next nephron, where this one will come in, do all crazy stuff, and then come back out. It goes from one to one to one. Keeps going across. Because these are arterioles, remember arterioles have the greatest resistance. That's the site of resistance, is at the arterioles. And because we have an afferent arteriole and an efferent arteriole, we can alter how much blood stays in the glomerulus by altering the afferent or the efferent diameters. We can play around with how much blood stays in that glomerular capillary, feeding more GFR. Yes?
So it goes out from the first one as efferent, and before it gets to the second one,
It just turns into an afferent. We also have these peritubular capillaries, and they just surround the entire nephron, and that's where we get the reabsorption goes into those peritubular capillaries, or the further secretion occurs with these peritubular capillaries. And the vasa recta is there mainly to help with storing blood. That vasa recta, remember, the vasa recta is part of those juxtamedullary nephrons, which go all the way into the medulla, and they help conserve blood during periods of hypovolemia. So this graph is just talking about what we talked about before. Sites of largest vascular resistance, and they occur afferent arteriole, efferent arteriole. See how much this drops in those two areas? Because they are the arterioles, and that's where we can control those diameters very, very easily. So we can alter those things to alter renal blood flow. So normally high rates of renal perfusion provide large excess for O2 for tissue metabolism. In any state of shock, the kidney is very easily damaged and injured. Persistent low renal perfusion may result in acute renal failure. You're not getting enough blood to the kidneys, they get ischemic, lack of O2, they become stressed very, very, very fast. So that's why renal blood flow is very important to maintain. So clinical correlation, when we talk about renal failure, there's two types, acute and chronic. Acute, over hours to days. The chronic one is persistently low kidney function for over 3 months. You don't have to know that now, I'm just telling you what it is. And then even within the acute renal failure, you can find out where the problem is. Is it before the kidneys? That's considered pre-renal. Anything occurring before the kidneys. If the problem is the kidney tissue itself, nephron damage, whatever else is going on with the kidney itself, that's renal ARF or intrarenal. It's within the kidney is the problem. Or is the problem after the kidneys? So what's after the kidneys? Bladder, ureter, all the urination stuff. So anything affecting flow after the kidneys can cause kidney failure as well. So men who have BPH, benign prostatic hyperplasia, the prostate gets enlarged, the ureter runs right through or right on top of the prostate gland. Prostate gets bigger, it's going to pinch off the ureter or urethra at that point. Lack of urine flow. If the urine can't leave the bladder, do the kidneys know that? So what are the kidneys going to keep doing? More and more urine. You're going to keep making more urine. Eventually that urine is going to back up into the bladder, then up back into the kidneys. That's an example of what post-renal failure can do. Endocrine functions of the kidney, there are 3 of them. First one is renin. So I said before, here is the afferent arteriole, here's the efferent arteriole, here is that glomerular capillary, the glomerulus, which sits inside the Bowman's capsule. And here is that distal convoluted tubule, and you can see these cells that are sitting right there. Those cells will sense the blood going through the kidney, and if it senses low blood volume, it's going to release renin into the bloodstream. Okay, starts the renin cascade. We're going to deal with the renin cascade more in detail in the endocrine section. We're not going to deal with it right now. Just know it kicks off the renin cascade due to low blood volume. Not low pressure. Volume of blood is the problem. So that's that's renin. The next one, EPO secretion, erythropoietin. We've already discussed this a bunch of times already. Low O2 tension in the blood. Kidneys pick it up, start pumping out EPO. The goal is to do what with EPO? More red blood cells. What's that going to do to the oxygen carrying capacity of the blood? Increase it, so we're back to normal, then EPO shuts off. That's another function of the kidneys. Another one, activation of vitamin D. Okay, so we get vitamin D from sunlight or diet. Those are the major ways we get vitamin D. It's then synthesized in an inactive form in the liver. So the liver makes the inactive vitamin D. It has to get to the kidneys where it's converted to the active vitamin D, which then can help with calcium absorption. We'll get to vitamin D more when we get to GI when it comes to calcium. Okay, you need vitamin D for calcium absorption. That's why if anyone's taking calcium supplements, they need to take vitamin D with it, because if you don't, all that calcium, you're just going to poop it out probably. You're not going to use it because there's no way to get it in. You need the extra vitamin D for that. So that is what another hormonal thing that the kidneys do, vitamin D activation. So if someone has kidney failure, the kidneys aren't working well anymore, what conditions do you have to start watching out for in people who have chronic renal failure? Osteoporosis. Why? We're not activating vitamin D. We're not getting calcium. Nothing's going to go into the bone. The bones get weaker. So you have to worry about osteoporosis for a renal failure patient. What else do you have to worry about? Anemias. They're not going to make enough EPO. So you're going to have anemia with these chronic renal failure. They're not having enough EPO to be released. And the aldosterone, the renin system, we'll get that a lot more when we get to endocrine and how that works. Okay, so let's talk about how we actually filter our blood to create urine. The filter should not allow blood cells or plasma proteins to leak into it. So you should never see red blood cells and you should never see protein. Okay, who's here worked as a lab before, MA? Okay, so what are the things you look at in the urine? Don't you do a dipstick? And what are you checking for in the dipstick? Proteins, red blood cells, glucose, and other things, but you're measuring those things. You should not have any protein in the urine. If you're losing protein in the urine, where's that protein coming from? The blood. What's going to happen to the protein concentration of the blood? It's going to decrease. If that happens, what happens to your oncotic pressure? Decreases as well. If your oncotic pressure decreases, are you going to swell up with fluid or are you going to shrink? Swell, because you don't have that suck anymore. So people who have urine that has a lot of protein in there may have trouble with edema because they're losing the protein and it's going into the urine. We don't want that to happen. We want the protein to stay in the blood to provide its oncotic pressure. So we also have to use our hydrostatic pressures here, our oncotic pressures here. They're very important here when we talk about glomerular filtration. And we know that our GFR is stable because of the autoregulation, but we can mess around with the afferent arteriole, we can mess around with the efferent arteriole to alter our renal blood flow in order to improve GFR or decrease GFR. And again, what's the main homeostatic variable for the renal system? ECF concentration. That's the goal. Maintain ECF. Whatever excess, dump in the urine. If we need it back, we'll reabsorb it from the filtrate and get it back into the plasma. So a couple of clinical correlations here. Glomerulonephritis is injury to the glomerulus, and they may either have protein in the blood or they may have blood cells in the blood. But you have a damage to the filtration system, allowing these things to leak in. You don't need to know anything about that, what nephrotic or nephritic is. So we have a barrier set up. So we don't let certain things get in. Red blood cells, proteins. We don't want those to go into the urine. We want them to stay in the plasma, in the blood. So the first thing we filter for is molecular size. Okay. We look at molecular size. We call it kilodaltons is the unit of measure. That's why it's there. But basically, anything less than 10 are freely filtered. They're small enough they can get through those fenestrations, they can get into the filtrate, and to be cleared. From 10 to 70, as you get bigger and bigger molecules, there's a linear decline in what can get through. Albumin. What's albumin? It's our protein. Okay? It's right at 70 kilodaltons for the size. Proteins are very big molecules. They're huge. So it's almost small enough to be filtered, but again, it's very essential that proteins don't get filtered. They got to stay in the blood. They have to stay in the plasma. And again, albumin is the largest contributor to plasma oncotic pressure. That's why it's important for the plasma. You see how things are connecting now all back to the heart, and that's why I always focus on the heart with you guys more, because everything is going to go and affect it. So molecular size. How big is the particle? Anything bigger than 70 kilodaltons, we don't let through. The next one, electrical charge. Okay, less filtration of negatively charged molecules compared to neutral of the same size. So anything negative will not get through that barrier. Why at pH of 7.4, is that normal? 7.4, is that a normal pH? What's normal? 7.35 to 7.45. So at 7.4, we're at a normal pH for the blood. And at a normal pH, proteins are a net negative charge. So if the space, the barrier is negative, the proteins are negative, they're going to get repelled and stay in the plasma. They're not going to get through because it's negative space. It's a negatively charged molecule. They repel. So that's electrical charge. Molecular size. The last little bit are the anatomic structures that the solute has to pass through. We have the glomerular capillary endothelial cell layer. Okay, so the capillary, we have to get through the capillary wall. We have fenestrations there that only exclude blood cells. So this capillary barrier doesn't let red blood cells to get there. So if you see red blood cells in the urine, that means that your glomerular capillary has been damaged, allowing the size of those red blood cells to get in. Then we have our glomerular basement membrane, and this is a fiber meshwork. It acts like a sieve. So we have, things set up. Anything bigger won't get through. It's too big. It can't get through. But little molecules can get through. That's all it is for size. It's a mesh network, just like a colander. If you're cooking pasta and you gotta drain it. Okay, same thing. If those holes were huge, whatever type of pasta can fall through. Same thing with the kidneys with this mesh network. We also have podocytes here. Where else did we see podocytes before? Blood-brain barrier, as someone say over here, right? What cells provide the podocytes in the astrocytes? Provide the podocyte, which effectively gives you that blood-brain barrier. Same thing here. Okay, specialized endothelial cells provide narrow filtration slits by that protein called nephrin. And again, fixed negative charges are present in the basement membrane and these filtration slits, so anything negative will not get through. So size and charge is how the kidneys filter out stuff. Got to be the right size to get through the filter, the right charge to get through as well. So this is a filtration membrane. I do want to focus on the bottom part though. We're talking about the filtration pressures. So the top part kind of just talks about what we already talked about, how certain sizes can get through and the negative charges, but the bottom part is more about the filtration that I want you guys to focus on. Here it is. Okay. Okay, so hydrostatic pressure. That's the push or the suck. Oncotic pressure, push or the suck? Suck. Okay. Now let's set up our system here. The left side is the glomerular capillary. The right side is the Bowman's capsule. So the GC is the glomerular capillary, the afferent and the efferent that goes through. The afferent feeds into the glomerular capillary, wraps around, bundles itself up inside that Bowman's capsule, where we have pressures built up. Now, in the glomerular capillary, we have two forces. We have, let me put it in their color. We have the hydrostatic pressure of the glomerular capillary, and that's at 60. And we have the oncotic pressure. I'll put it in that purple as well. The oncotic pressure of the glomerular capillary, and that is sitting around 29. Okay, so that is what's going on in the glomerular capillary. Yes?
Just to confirm, the glomerular capillary is sitting in Bowman's capsule?
Mm-hmm. Now, on the Bowman's capsule side, we also have a hydrostatic pressure, and that is going to be on the Bowman's capsule side. Hydrostatic pressure of the Bowman's capsule is 15. And oncotic pressure of the Bowman's capsule should be what? 0, right? Why should it be 0? Should there be any protein in the Bowman's capsule in the filtrate? Nope. So the oncotic pressure should always be 0 in the Bowman's capsule. Everyone good with that setup? So let's calculate it out and have it make sense. So we have the factors that okay, so we set up our calculation that way. We have the factors that favor filtration minus the ones that oppose it. So which factors that we listed before are going to favor filtration? Hydrostatic pressure of what? Glomerular capillary, right? That's going to favor filtration. What other value will favor filtration? The oncotic pressure of what side is going to favor filtration? Bowman's capsule. That number is going to favor filtration. Then we're going to subtract all that from the forces that oppose filtration. The hydrostatic pressure of the Bowman's capsule, the higher that gets, the worse filtration is going to get, right? Because that gradient is going to get smaller. Minus oncotic pressure of what? Glomerular capillary. This is going to oppose filtration. So what's the pressure in the glomerular capillary? Oh, these are supposed to be added. So it's 60 plus, what's the pressure in the Bowman's capsule, the oncotic pressure in the Bowman's capsule? 0. Minus, what's the hydrostatic pressure in the Bowman's capsule? 15. Plus, what's the oncotic pressure in the glomerular capillary? 29. So it's 60 minus 15 plus 29 is 34? 44. And that equals what? 60 minus 44? Is it positive or negative? Positive 16. Because it's positive, what is the net effect going to be? Filtration or absorption? Filtration. If that number goes negative, then it is suck. It's pulling it back in. Going to resist filtration. Any questions about filtration, push, oncotic pressures, hydrostatic pressures? Make sure you get them all squared away. So one of the diseases that you'll learn about later on, loss of nephrin, which is that big protein that allows for all this stuff to happen. It's called minimal change disease, allows loss of albumin. So it's called nephrotic syndrome. So this happens a lot in kids. So what do you think this child will present? How are they going to look if they have nephrotic syndrome they're coming to see, or the minimal change disease, where they're dumping protein in the urine? How are they going to look? Swollen. They're going to be puffy eyes underneath. Swollen. They're going to look like they're fluid overloaded because they have too much fluid in the body. So that's what minimal change disease is. Again, just showing you that why protein is so important to stay in the glomerular capillary. So the next little bit here is talking about how we determine our GFR. Basically, all I want you to know about this. GFR is the product of the driving pressure forcing fluid out of the capillary, which is the filtration, and the permeability of that filtration. So you need both things there. Enough driving pressure. What provides the driving pressure for filtration? What? Well, yes, but just basically renal blood flow. Renal blood flow is the first part, the net driving pressure. Hydrostatic pressure is off of blood. So how much blood are we getting to the kidneys? Is there even blood getting to the kidney? If not, nothing's going to be filtered, but if there's blood getting there, then we'll have some filtration going on. And then the next part, can we even filter that substrate at all? Okay, protein should have 0 because we shouldn't, proteins are getting through the capillaries. They're getting to that area, but they're not getting filtrated because they're too big of a particle. So the GFR for that will be 0 because for protein, there's nothing there. So for every cyclic ion, they're going to have their own way to get filtrated. So this graph looks very confusing, but we'll go step by step and we'll point it out. Pressure. This is the oncotic pressure or the hydrostatic pressure is what we're talking about here. Just pressure in general. And on the x-axis, we have the length of the capillary. So we have the afferent side over here, and we have the efferent side on the other side. I'll put that in real colors for you. First thing, hydrostatic pressure in the Bowman space. We've said before, it's 10, and it's 10 the entire length. So the hydrostatic pressure in the Bowman's capsule, Bowman space, should be constant the entire time. Now, let's look at the blue part. Hydrostatic pressure in the glomerular capillary. So we're in the capillary. What do you notice about that blue line? Is it straight? Is it angled down? Is it angled up? It's going down, which means that as you go the length of this capillary, hydrostatic pressure starts to drop. Why is hydrostatic pressure start to drop as you go along the length of the capillary? What's happening? What are you? You're filtering out. So what are you losing? Volume of blood. If your volume of blood goes down, the hydrostatic pressure goes down as well. So that's the blue line. That's the hydrostatic pressure in the glomerular capillary. So that's that line. The last bit we have to talk about is our glomerular capillary plasma, the oncotic pressure in the glomerular capillary. As you go along the length of this capillary, the oncotic pressure is getting stronger, right? Do you see how this line is going up? The oncotic pressure as you go along the length of the capillary starts to exert a greater force. Why is the oncotic pressure as you go along the length of the capillary exerting a greater oncotic force? We're filtrating the blood, right? So what are we losing? Plasma. So the hydrostatic pressure is going down. However, the concentration that the plasma proteins now exert is greater because there's less volume of blood, less solvent, right? So the solute goes up in concentration. Does everyone get that? So as we go along the length of the capillary, the hydrostatic pressure is dropping, meaning the oncotic pressure can now start to exert a greater force. Right here, this filtration equilibrium is when the hydrostatic pressure and the glomerular oncotic pressure match. Okay, now the last piece of this puzzle is all that yellow. All that yellow, all that area is what is actually being filtered into the urine. That's why it's, yellow. That is actually what is going to be forming the urine. So that first half of the capillary, we get filtration. The second half of the capillary, there's no more filtration anymore. We've hit an equilibrium between hydrostatic pressure and oncotic pressure. There's no more net movement. That's why this area under the curve goes away when you get to that filtration equilibrium. The pressures even out. There's no more net movement of fluid, and therefore everything else stays the same the rest of the way through. Then this blood goes to the next nephron. The whole process starts over again. So this kind of tells you how we filter in the first part of the arteriole because the hydrostatic pressure is the strongest. The last half, the pressures even out, and there's no more filtration. Okay, let's take a, no, let's wait, 1:30. We start, yeah, it's an hour. Okay, we'll take a break now. Come back at 1:40. Okay, quick announcement for PAs. Okay, I need to know, for PAs in your last anatomy quiz, what group went at 8 a.m.? Was it A or B? B. Okay, so group A will be at 8 a.m. tomorrow morning. Group B will be at 10 for the anatomy quiz. You have open PD lab the entire time for practice. Feel free to go in there and out when you're not in lab. You will have anatomy lab tomorrow. So the 8 a.m. group will go from 8 to 8:30 for your quiz, and then 8:30 to 10 for your lab, and then same as over. So what group is going first again? A is at 8 a.m., okay.
And it's just identifying structure.
Identifying, we'll have a pin in the structure. Same thing as last time. You just, what's the structure? You write it down.
So just to confirm,
Yeah.
after the quiz, we don't have to stay in anatomy lab, we can go to PD?
No, you have lab still tomorrow. You still have anatomy lab. You just don't have PD lab tomorrow. That's the only difference. There's no like,
Oh, okay.
so PD is an open, you just go and practice with your partner if you want. When you're not in anatomy lab. You had a question? Yeah, you can wear your PD uniform, that's fine. That's fine. Yes, you can wear scrubs. You can wear scrubs tomorrow, it's fine. Scrubs are fine. Yes, all day. I'll make the announcement, I'll tell everyone else. It's okay. Okay, so we mentioned before the two greatest sites for developing resistance in the renal system are what two arteries, arterioles? Afferent and the efferent arteriole. We can alter those things to alter renal blood flow. And if you alter renal blood flow, what also will that alter? GFR. Okay, so GFR is what we're trying to get to. Norepinephrine preferentially constricts the afferent arteriole. Does that make sense? What? And what is that going to do during periods of like fight or flight? It's going to direct the blood away from the renal system. What would happen if norepinephrine constricted the efferent arteriole? You would still get blood in their kidneys because the glomerular capillary is before the efferent. Okay? So norepinephrine has a preference for the afferent arteriole. That's very important to know and remember it. Norepinephrine has a preference for the afferent arteriole, reducing renal blood flow, GFR, sodium excretion. If we're not excreting sodium, where is the sodium going to stay? In the blood. If sodium stays in the blood, what's going to come along for the ride with it? Water, maintaining your blood volume, which is also going to maintain your blood pressure. Okay? Angiotensin II, which is part of that renin cascade that we haven't really got into a whole lot, but angiotensin II is one of the byproduct, one of the steps along the way. That has a very strong preference for the efferent arterioles. Okay, and we're going to walk through each one of these step by step as far as what happens when you alter the afferent or the efferent arteriole. And that's what this picture is, but I'm going to redraw it in black on this one, but you can follow along. It's going to be the same exact thing. I'm just doing it different than what you see on there. Okay, so we have this is the afferent. Here's the efferent. And there's that glomerular capillary in the middle. And also, this is the Bowman space. It's right around there. So we have our afferent and we have our efferent arteriole, and we have blood coming in that's going to get filtered. Okay, so normally blood comes in this direction. As it gets into the capillary, it's going to exert a hydrostatic pressure of the glomerular capillary. And that hydrostatic pressure is going to exert out, right? It provides the push, and then eventually blood's going to work its way out. This hydrostatic pressure that's exerted inside, so we have this hydrostatic pressure of the glomerular capillary, which provides constant renal blood flow, which means we have a constant GFR. So long as everything's okay, we have normal tone in our afferent versus the efferent, everything's going to be fine going all the way through. Any questions about how we set this up right now? Okay, now, what we're going to do is we are only going to deal with the afferent side right now, just the afferents. And what we're going to do is we're going to vasodilate. Let me change this. We're going to vasodilate that afferent arteriole. Okay? We're going to vasodilate just the afferent arteriole going into the glomerular capillary. In this situation, because we vasodilated the afferent, what is going to happen to the hydrostatic pressure inside that glomerular capillary? It's going to increased. Because more blood is getting into the space now. We've vasodilated the afferents. More blood can get in. More blood exerts a higher hydrostatic pressure. What is that going to cause to renal blood flow? And what's going to happen to the GFR in this case? So if you vasodilate the afferent arteriole, you're going to increase GFR, provide more filtration for the kidneys. Everyone good there? Okay. Now, same setup. Now, we are going to constrict that afferent arteriole. So now we're constricting it. If we constrict the afferent arteriole, what's going to happen to the blood that gets in there? Decreased, right? Less blood's getting in. What's going to happen to the hydrostatic pressure? What happens to the renal blood flow? What happens to GFR? So if you constrict the afferent arteriole, you're going to decrease renal blood flow, decreasing hydrostatic pressure, decreasing GFR. That's all you got to know as far as what happens with the afferent arteriole. Just two things. You constrict it or you dilate it. What happens to renal blood flow? What happens to GFR when that happens? Everyone good on the afferent side? What is going to target this afferent arteriole to constrict? Norepinephrine, right? It's the only one that does it. Well, it's not the only one, but it's the major one. So that's the afferent side. Now, let's talk about the efferent side of things. So we have our artery, glomerular capillary. Is there afferent, efferent, glomerular capillary? So we are only going to deal with the efferent side now. So let's say we dilate it. Cause extreme vasodilation of the efferent side. What is going to happen to that blood as it goes through this system? Is it going to go through very fast or going to go through very slow? Well, think about traffic. If you're in a traffic jam and the GC is the traffic and then it expands open, everyone just takes off and goes. So in this case, when you dilate the efferent side, blood goes too fast through the system. Hold on. It does increase. Hang on. Let me just write this right away. Okay. Blood flow will get through faster. More blood's going to get through. However, where is it getting backed up? In the glomerular capillary. So we have all this blood moving out. So blood's leaving. What's going to happen to the blood in the glomerular capillary? If blood is going out too fast, leaving fast, what's going to happen to the hydrostatic pressure in the glomerular capillary? Decreased. So we actually get increase in renal blood flow, but because it's on the efferent side, it decreases hydrostatic pressure of the glomerular capillary, which in turn is going to do what to the GFR? Decrease the GFR. So if you vasodilate the efferent arteriole, renal blood flow does go up, but GFR goes down because you reduce the hydrostatic pressure. The blood's not sitting in that glomerular capillary long enough anymore because the renal blood flow is going so fast because we dilated the efferent side. It's just pouring out fast. So it's not enough for a hydrostatic pressure to go up. Now, let's take this same setup. Now, we are going to severely, or not, we're going to do a minor, we'll call this minor constriction. Of the efferent arteriole. So we're going to constrict the exit now. So what's going to happen to renal blood flow in this case? Decrease. But where is all this blood collecting right now? In the glomerular capillary. So what's going to happen to your hydrostatic pressure of the glomerular capillary when you constrict the efferent arteriole? Increased, right? So we increase hydrostatic pressure of the glomerular capillary. If I do that, what happens to your GFR? Increases the GFR. So with minor constriction of the efferent arteriole, you will increase the GFR. What hormone constricts the efferent arteriole? Angiotensin II. Okay, angiotensin II is in the efferent, norepinephrine is on the afferent. There's a drug that we give that blocks the making of angiotensin II. Anyone know what that drug is? Or class of drugs? Form of diuretic. So ACE inhibitors, angiotensin converting enzyme inhibitor. If you give someone that drug, what is that going to do to their efferent arteriole? We're preventing the conversion of angiotensin II, so we have less of it. What's going to happen? It's going to dilate. What happens if you give someone who has kidney failure already an ACE inhibitor? What's going to happen to their GFR? It's going to get even worse. That's why you don't give ACE inhibitors to kidney patients, because you're going to mess up with their glomerular filtration, making the GFR worse if you give them an ACE inhibitor, because you're affecting the efferent side. Now, there's one final thing that happens with the efferent side. And this, the last little bit here, we're going to call it extreme constriction. Okay, so we'll call this efferent extreme constriction. Now, what happens with the extreme one is a little bit different. In this case, what is going to happen to your renal blood flow? It is going to decrease. So we know our renal blood flow does decrease because we've constricted the efferent, we've constricted the exit. There's nowhere for it to go, so it's got to stay in here. When you have extreme constriction, this blood starts to get stuck in this area. What's in the blood that exerts another pressure, that's going to start building up in this area as more and more blood comes into it, gets stuck. Proteins are going to start building up in this area now with extreme constriction. If proteins start building up again, what pressure is going to go up? Oncotic pressure. So in extreme constriction, we get an increase in our hydrostatic pressure of the glomerular capillary. Increasing oncotic pressure, is that going to favor filtration or oppose filtration? Oppose it. So if our oncotic pressure went up, GFR is going to go down. So with extreme constriction of that efferent arteriole, you get decreased GFR because the oncotic pressure builds up a lot. And that exerts a stronger force now. So those are the 5 things you got to know about the afferent and the efferent. Afferent only has vasodilate or constrict. The efferent has vasodilate, constrict, but also has the extreme constriction. So, yes, yes.
Is the oncotic pressure going up in the Bowman capsule, or is it in the
Glomerular capillary, because the blood can't leave. So the blood's building up in the capillary, so more proteins are getting there, bigger oncotic pressure. So those are the different things you got to know as far as how we can constrict the afferent and the efferent, what happens to GFR. Okay? Any questions about how that works? Yes?
With the extreme constriction,
Yes.
do we talk about hydrostatic pressure here?
It's there. Hydrostatic pressure is there, but because the blood's not really moving, but more blood keeps coming in, there's more proteins coming in, that will overwhelm the hydrostatic pressure.
Okay.
Only with extreme constriction. In normal constriction, the hydrostatic pressure is still strong enough and it still wins. It's only with the extreme where it changes. Yes?
Is it safe to say that hydrostatic pressure is proportional to the GFR?
Not in all cases, but usually it is. Yep, it seems to be that way, most all of them. Except for extreme one. Because extreme, the hydrostatic pressure will build up, but the oncotic pressure is stronger in the extreme one, and then GFR goes down. That's the only one that's off. Everything else, yes, they go that way. Yes?
So in the extreme, hydrostatic pressure is also decreased.
It is, but it's not as much as the oncotic. So the oncotic pressure is going to win now when you have extreme constriction, because the proteins will start building up in that glomerular capillary. Okay. Okay, NSAIDs. Inhibit prostaglandins, which are the primary endogenous vasodilators of the afferent arteriole. NSAIDs, if you give them to patients who have kidney failure, kidney failure can get worse. Why? If you give NSAIDs, it inhibits prostaglandins, which are the vasodilatory mechanism for the afferents. If you block that, is anything going to make those afferents dilate? No. So we're going to be constricted. So reducing prostaglandin levels causes constriction of the afferent arteriole, decreases your GFR, making the kidneys worse. So if people already have kidney failure, don't give them Motrin, ibuprofen, naproxen, naproxen. Those are all NSAIDs. They can make your kidney function worse. And then there's your ACE one I talked about already with the angiotensin converting enzyme. Okay, let's talk about clearance now. So clearance is the volume of plasma rendered free of a given substance in 1 minute. In 1 minute, how much can we get rid of a substance in 1 minute? And we're going to filter it out, obviously, in our kidneys. So renal clearance is often applied as a specific marker of molecules as a means of estimating the GFR. We use creatinine as the molecule for clearance. You don't have to know this formula. Don't worry about it. So why do we use creatinine? The product of muscle metabolism. The rate of creatinine production is constant because it's a function of muscle mass. Creatinine clearance overestimates GFR by about 10%. That's why I like to use GFR for assessing kidney function, not so much creatinine. So because creatinine production is constant, the excretion rate, how much we can clear it, is going to depend on your GFR. Therefore, plasma creatinine is a direct index of GFR. As your GFR goes down, we can't filter as much. More of that creatinine is going to remain in the blood. So your creatinine levels go up because you can't clear it anymore because your kidneys aren't working as well. So if GFR goes down, creatinine goes up. If GFR goes up, creatinine goes down because your kidneys are working better and you can clear it easier from the plasma. And you can clear the creatinine away. That's why we use creatinine. Now, why creatinine isn't a great marker sometimes? Because it is a function of muscle mass. The bigger the person, the higher the creatinine is going to be regardless. And a smaller person will have a lower creatinine. If you took those two, looked at them side by side, you can't just say, well, this person's creatinine is 1.4, this one is 0.9, the 1.4 must have worse kidneys. You have to look at the size of the person, the BMI. The amount of muscle is going to alter the amount of creatinine in the blood. That's why GFR is a much better marker for that. Now, we want to quantify our tubular function. We look at two different things, a filtered load and an excretion rate. The filtered load is what is filtered by unit time. How much is dumped right into that glomerular capsule? Okay, how much was dumped in there at a given time? The excretion rate is how much is excreted. How do you measure the excretion? What are you going to test? The urine. We know how much I'm giving you. I want to see how much your urine you're producing of that same substance. So, if the filtered load is greater than the excretion rate, that means we had to reabsorb some of those solids. We dumped in 100, or we've only excreted 90, so we reabsorbed 10 units. We took some back. If the excretion rate is greater than the filtered load, where is everything filtered? Where does this filtration occur? Only in the Bowman's capsule. That's it. So if I filtered in the Bowman's capsule 90 units of whatever, in the urine I tested and you had 100 units of that substance. You had to have gotten 10 more units somewhere. Only way we can do that is by filtration or secretion. So you get secretion. You're secreting more of that substrate somewhere else along the tubule. You're adding in more stuff. Then we look at what the fractional excretion is. It's just a percentage. You know, we put in 100, we got 90 out. The excretion rate is 90%. Make sense? That's all we're looking at. What percent versus what was out. Okay. So we call it creatinine or clearance ratio, but it's the rate of solute clearance to creatinine clearance. We kind of measure things against the creatinine to see how well things go. So that's how you can quantify how much is being dumped out in the tubes. So clearance and plasma concentration. The clearance of a solute may change as a function of plasma concentration. So let's take glucose for an example. If you eat a very high sugary meal, you're going to filter more glucose than normal because there's more of it inside. That's all that's saying there. You have more glucose than you need, you're going to filter more glucose than normal because you're eating more of it, or you're diabetic. So glucose is normally not found in the urine with normal plasma concentrations. So that's what I'm saying. If you start seeing glucose in the urine, that means they've had high sugars for a long time. That's not just, oh, I had a big meal last night. No, you've been spilling glucose in there for a long time. It doesn't happen overnight. If plasma glucose increases, like in diabetes, the filtered load increases, and the rate at which we can reabsorb all these things can get saturated, meaning we don't have enough mechanisms to bring back all the glucose back into your bloodstream. If you can't do that, where's the glucose going to wind up? In the urine. So that tells us when you see people who have glucose in the urine that they've already maximized all the mechanisms to reabsorb the glucose because they have so much of it in their blood. We have a picture in the next slide. I'll go over this more for you. So that's why glucose spills into urine in diabetics with poor glucose control. Okay. You know, so there's one company, I don't know who it is, but they make whiskey or bourbon using distilled urine from diabetics because of the sugar content in the urine. I don't know who it is. There's one company that does it. That's true, yeah. There's also a company that will take coffee beans that squirrels eat and then poop out, and they'll roast the coffee beans because they doesn't digest the bean or something. I don't know. Okay, this graph, let's kind of walk through this graph and what it's trying to tell us. We have on the y-axis the glucose that's moving for filtration. On the x-axis, we have what our plasma glucose is. What is your glucose in the blood? What's the normal glucose range? 60 to 100, and that's that range right there. That's your normal physiological range in that beige bar. Now, the purple line is talking about filtered load. As our concentration of glucose increases, the filtered load goes along with it. Just makes sense. We have more glucose in our blood, therefore we're going to filter more glucose. Now, the green line is talking about our reabsorption. So long as this green line we follow, and at a certain point we start to even out and we can't reabsorb anymore. When we hit that TM, that's talking about our transport mechanisms. How many ways or mechanisms we have available to get rid of glucose out of the filtrate and bring it back into the blood. We're going to reabsorb this glucose. But after a certain level, we can't reabsorb anymore. We don't have the mechanism in our kidney. We're going to saturate all those receptors to pull the glucose back in. But we still have even more glucose in our blood. If you look at the red line, it's talking about the excretion. If we're excreting it, we're going to be able to sense it in the urine. So if you look at this threshold number, it's right around 200. Over 200 plasma glucose, as you get higher and higher, we're going to start excreting more and more into the urine because we can't reabsorb anymore. All of our transport mechanisms to reabsorb glucose have all been saturated because we have way too much glucose in the bloodstream. So it builds up, we can't reabsorb anymore. Anything after that gets excreted in the urine, and then you start getting glucose detection in the urine. Yes?
What happens when diabetics start to get kidney damage? Where does that, if they can't excrete it, where does it
although they can excrete it, the problem is they're losing other things with it, like protein, like all the filtration stuff goes to whack, and they start losing blood and proteins and other things. So this reabsorption, the reason why it has this little thing on there, this is called splay. When it starts, the reabsorption starts to trail off and become flat. The reason why you have this nice little gradual curve is because not all the nephrons turn on and get saturated or turn off at the same rate. So over time, you start losing more nephrons, losing more and more and more, and eventually this line levels off because you just don't have the mechanism anymore. You've saturated them all. All those nephrons are used up, can't reabsorb any more glucose, so we spill it into the urine, and your excretion goes up. So look at the filtered load. That purple line is going to be constant. As we increase our blood glucose, this number keeps going up and up and up. The reabsorption over 200, we slow down our reabsorption of glucose because all the transport mechanisms are used up and we can't reabsorb any more glucose, so it spills into the urine. That's why over 200, we start getting excretion. This will detect glucose in the urine at that point. Now it's being excreted, it's going to show up in the urine. And you'll test it, and you guys will see the urine. So again, as long as you're in this range right there, you're fine. Everything that's being filtered is being reabsorbed. There is nothing showing up in the excretion. You're okay. There's going to be no glucose in the urine. But when your glucose levels rise too much, our kidneys can't keep up with the amount, and you get excretion in the urine. And don't worry about that. Okay. What time is it? Okay, let's come back at 2:30. Take a break. Come back at 2:30. We'll start sodium. Okay, we'll get started, and we won't be here for another 2 hours. We'll be out of here in about another hour, so we're not staying the whole time. So we went through the parts of the nephron. We went through how we can alter renal blood flow to alter GFR. Now we'll talk about the different ions and how they are handled by the renal system. Sodium is an important one, and potassium are the two big ones that we're going to go through. There's other ones in there sprinkled throughout, but potassium and the sodium are going to be the biggest ones. So a couple of things. The daily filtered load of sodium is much, much more higher than the excretion. So what does that mean? Where is the majority of the sodium going to stay? In the blood. Because the filtered load is higher than the excretion rate. So we're dumping a lot in there, but we're reabsorbing the majority of it back out. If it's necessary to reduce the extracellular fluid, edema, high blood pressure, you can lower the blood volume. That's why we give diuretics for blood pressure. Lower the water, lower the plasma, lower the volume, lower the pressure. So we can increase salt and water excretion. Wherever salt goes, water is going to go with it. And filtration and reabsorption are the only significant process affecting sodium and water excretion. And most of the diuretics that we give inhibit tubular sodium reabsorption. So if I block the reabsorption of sodium, where is the sodium going to stay? In the urine. If sodium stays in the urine, what's also going to stay in the urine with it? What you're going to do what with it? Pee it out eventually. So that's how you lose water weight. Okay? And that's how diuretics work. And we're going to go through the diuretics. Now, when it comes to sodium, we know that 100% of that sodium is dumped into the filtrate, right? That's our filtered load. Everything gets dumped into that Bowman's capsule. Then, in the proximal tubule, 65 to 75% of that sodium that was dumped into the tubes gets reabsorbed. So remember I gave you that example before about filling a water bottle. The majority of it happens at first. As you go down the nephron, you're going to see this number get smaller and smaller and smaller. So 65, 75% of all sodium is reabsorbed in the proximal tubule. In the loop of Henle, another 15 to 20%, mainly in that thick ascending limb. Another 15 to 20% of the filtered load of sodium gets reabsorbed. Now we're at the distal convoluted tubule, and I said as you get to the more distal end, it's under more fine control, hormonal control. Only 5% in the distal tubule and a little bit left can get taken out in the collecting duct. So that last little bit, that last little 10% is under hormonal control at the very end. The bulk of sodium reabsorption occurs in the proximal tubule. Why this is important, because when we talk about diuretics, where certain diuretics have an effect on the kidney will produce different things. Okay, we're going to skip this drawing. We'll go right to this one. This first drawing is just talking about what happens in the proximal tubule. Diuretics have no effect on the proximal tubule, so don't worry about, just know that sodium gets reabsorbed in the proximal tubule, the bulk of it, 65 to 25% here, but I want to focus on this one. So we have the ascending limb, the early distal tubule, and that late distal tubule collecting duct. These are three areas where we have sodium movement: thick ascending limb, the distal tubule, and the collecting duct. Those are the three areas that we talked about right there. This area, and that area. That's what we're focusing on now with this drawing. So the thick ascending limb, we'll deal with this one first. Okay. This big protein right here is a triple transporter. It's responsible, it's got a sodium receptor, potassium receptor, and two chloride receptors. So two of them go in there, but basically it's a triple transport. All three molecules. Once all three molecules have bound to that receptor, then sodium and potassium can then leave. Well, sodium and chloride, I'm sorry. So sodium comes out that way, and the chloride comes out that way. The green one is just the sodium-potassium ATPase pump. So let's pump the sodium out and bring in the K in. So this is what happens in the thick ascending limb. Okay, this is the fluid or the urine. Here's the lumen wall, interstitial space, and blood. So in the thick ascending limb, it's a triple transport. Once all three are bound, sodium and chloride can get through and go out where they got to go. Now, the diuretic that works in this space, these are called loop diuretics because they work at the loop of Henle. The thick ascending limb, it's called a loop diuretic. So from here on out, if you ever hear anything about a loop diuretic, it's going to attack the thick ascending limb. And what the loop diuretic does, let me just change the color here. What the diuretic does, it blocks just the chloride receptor. This is a triple transport. All three molecules have to be bound for the whole thing to work. So, by blocking the chloride receptor, chloride can't sit in it, the whole thing doesn't work. So where does the sodium stay? In the urine. What also is going to stay in the urine? Potassium. So if you give someone a loop diuretic, you need to check potassium levels as well, because they're going to lose potassium also because you're shutting off the whole transport. So potassium is going to stay in the urine, not in the blood, because we give them a loop diuretic. These are called potassium wasting diuretics because you're wasting the potassium and it's going into the lumen, into the urine. So these are loop diuretics. The most common one, Lasix. Do you know why it's called Lasix? Because it lasts 6 hours. I'm not kidding. That's what they made it. Lasts 6 hours. So Lasix furosemide, anything that ends in mides, bumethidine, Bumex, those are all loop diuretics. They're going to block the chloride channel. The whole triple transport stops. No absorption of sodium, no absorption of water. We diurese. We're getting rid of all that water weight. So that's the thick ascending limb. Now let's talk about the early distal tubule. We're still in the distal nephron. This one just has a sodium and chloride channel. So this transporter, sodium and chloride. They both have to bind to that receptor, and then the whole thing works. Sodium will move, and then sodium will get out that way. So we're in the early distal tubule. We have diuretics that can hit this area as well. These diuretics are called thiazide diuretics. So thiazide diuretics, the most common one is hydrochlorothiazide, HCTZ. It's a diuretic. It attacks the distal tubule. Same thing, blocks the chloride receptor. And if for the whole mechanism to work, both substances have to be bound. But in these thiazide diuretics, we block the chloride. Sodium doesn't go anywhere. It stays in the lumen. Water stays in the lumen, and you diurese, and you lose water that way. So this is how your thiazide diuretics work. Okay? The last one, late distal tubule and the collecting duct. So this one has a bidirectional thing that's going on. This is all affected by hormones. So in this case, we have sodium going out, and we have potassium going in that direction. Okay, this is what's going on in the common collecting duct, late distal tubule, all the way to the very, very end. Now, look at the way this is set up. Are they going the same direction or opposite directions? Opposites. So, with these diuretics, these are called potassium-sparing diuretics. If I block the sodium channel from working, is the potassium going to get into the lumen? Same, these transporters. If I block the sodium, the potassium is not going to move either. If the potassium is not going into the lumen, where is the potassium going to stay? In the blood. That's why these are called potassium-sparing diuretics, because they're going to keep the potassium in the blood. The other one is that triple transport. They all go in the same direction. You knock it out, nothing can get through. But in the late distal tubule, this is under the effects of aldosterone. The drug that does this one, spironolactone, if you ever heard of that one. Spironolactone is an aldosterone. It acts like aldosterone. We'll get to this a lot more when we get to the endocrine stuff, but spironolactone acts like aldosterone, and it's potassium sparing. So in these patients, you don't have to worry about potassium dropping because they don't have the right mechanism like the loops do when it comes to potassium. So those are the three main classes of diuretics that you guys use. So this is a great mechanism showing where they work. The first are these carbonic anhydrase inhibitors. We didn't talk about them. They aren't used very much, but they're one example of this one that you would use this. Anyone would know what is the main reason you would ever want to use a carbonic anhydrase inhibitor? Where would you use it? Anyone know? So this is used for people who get high altitude mountain sickness. If they go hiking like the Everest, some of them will get acute pulmonary edema from the altitude and they get other problems going on. So acetazolamide is you don't have to know this one, but there's a drug called acetazolamide. It's a carbonic anhydrase inhibitor. So in your exam that I gave you credit back for, in the lungs, the carbonic anhydrase provides the stimulus to make CO2 and water. If I block that, what am I not producing anymore? Water, right? That's what I'm worried about. This is a diuretic now. I need to lose water. So carbonic anhydrase inhibitors, by blocking, we don't make water from that conversion, therefore less water. But it's not very effective for like heart failure patients. They don't do much. Osmotic diuresis is just exactly what it sounds like. It's osmosis due to movement of water, depending on what the concentrations are showing. But here we are. These are the loop diuretics in the thick ascending limb. Your thiazides, the early distal tubule, your potassium-sparing diuretics in the cortical collecting duct is where they have their effect. So this is a great slide. Make sure you know where these diuretics have their effect. Okay? Any questions about sodium and how diuretics work? Remember, the goal of diuretics is to get water weight off people who are fluid overloaded. There was a question on your exam. This was a multiple part thinking question. The patient had a low CVP in the ICU, right? So it was like 2. What is a normal CVP? Where should it be? 5. So the patient had a CVP level of 2. Do you need a increased blood volume? Oh, no, the patient had a 10, I think. But anyway, the point was you had to give a diuretic to get the weight off of them. The real key part was how do you deliver it to the patient? And I said you had a 2 centimeter long AC line or a 10 centimeter long central line. Based off about resistance, which one's going to provide the bigger resistance to flow? Central line or the AC? Central line. The length provides greater resistance. So in that question, best way to give fluid to someone is always AC, large bore, short length of a tube provides the least amount of resistance, greater flow for rehydration. Okay. So this is a summary slide. You don't need to know like the agents. These are just examples to show you, but mechanism of action is very important. Class, mechanism of action, and examples of the use you don't need to know either. But make sure you know the mechanism of action and the class and how they work. That's it for sodium. It's not much, just that. Urine concentration and dilution. So we have a certain amount of water we want in our body, and we can vary water excretion over wide ranges of plasma osmolarity. 3 processes are required for this to occur. 1, adequate GFR. We got to filter the blood. We got to have adequate renal blood flow going to the kidneys and to the water to the loop of Henle. 2nd, sodium reabsorption without water reabsorption in the ascending limb of the loop of Henle. So sodium reabsorption without water. This only occurs in the ascending loop. Okay, this is the potential to dilute the urine. Because we're only getting sodium out, the water is still staying in the urine. And 3, water permeability in the collecting duct must be variable. We mentioned before, the common collecting duct is that final bit of fine-tuning of your ECF. So we must be permeable to adjust it to when we need water to when we don't need water. And the hormone that does it is antidiuretic hormone, ADH. What is this also known as? Vasopressin. So vasopressin, ADH, same exact thing. But the ADH is what controls our water levels in our blood. So it's a variation in water excretion due to changes in plasma osmolarity. If our osmolarity goes up, what does that mean happened to the solutes? Increased. So how do we get that back down? Got to add more water to it. The way you do that is with ADH, anti-diuretic. So what's the goal of ADH? To retain water or to lose it? Retain water. ADH, anti-diuretic hormone. We have large increases in ADH secretion if osmolarity increases and or blood volume decreases. For hypovolemic, you're dehydrated, you need to retain more water, so we suck the water back in. That's why your urine gets darker and darker when you get dehydrated. ADH comes out and pulls that water right back into the plasma. ADH affects the kidney and it helps with concentrated urine, retention of solute-free water in the body. Very important to remember, ADH is only talking about water by itself. Free water, solute-free water, it's just water. There's no salt in it, there's nothing. It's just free water that ADH is able to control to either concentrate the urine, bring the water back in to the bloodstream, or dilute the urine by dumping out water out of the blood into the urine to bring our osmolarity up a little bit. Vasopressin, ADH, is a very potent vasoconstrictor. We have 2 different types of receptors for ADH in our body, V1 and V2. The V1 receptors actually causes the vasoconstriction. So any of you who were EMS, paramedic, ACLS, one of the drugs that you give is vasopressin. Why? For the potent vasoconstriction to bring your pressure back up again. So it's used in a life-saving way as well. We're going to be worrying about these V2 receptors. These V2 receptors are on that common collecting duct in the kidneys, in the nephron, and they're going to help with water excretion or reabsorption depending on what our body needs. So ADH is synthesized in the hypothalamus and secreted from nerve terminals in the posterior pituitary. Because it's a nervous input, is this response to your osmolarity going to be fast or slow? Fast. That's why you get a thirst sensation pretty fast when you're thirsty. That's why bars and clubs, whatever, give out salty peanuts so you get thirsty, so you drink and buy more beer or whatever. It's all a trick. Okay. We'll talk about ADH right now in alcohol because it does play a role. So reductions in plasma volume of more than 10% is a potent stimulus to cause your thirst drive and other things to happen. Low pressure baroreceptors in the atria and the lungs, they'll sense this drop in blood volume, and high pressure carotid baroreceptors as well will sense this. Nicotine increases the secretion of ADH. Does that mean that you're going to pee more or pee less? Pee less with nicotine. Ethanol, alcohol. What does ADH make ethanol do to ADH? It inhibits the secretion of ADH. What's going to make you do? Pee more. That's why if you're drinking and you break the seal, you got to keep peeing after that. It's because your ADH got reduced. So your body's thinking, hey, we got to dump all this water out. And then you start peeing like crazy. That's where drinking comes in with the ADH. And so with regards to ADH, there's a couple of things that happen. Whenever you talk about hormones, whenever you're studying them, always think about it. If I have too much of this hormone, what happens? And if I have too little of the hormone, what happens? That's all you got to know for like anything with endo. Just what happens when you have too much or too little. When you have too much ADH, it's called a syndrome of inappropriate ADH. We're pumping out way too much ADH. So with this continuous ADH secretion, we're going to reabsorb or retain all this solute-free water. Just water, water, water. All that water is going to dilute out your sodium, right? All your ions are going to go down because you're adding so much water to your plasma, everything drops. So you can cause a false hyponatremia because you diluted out all the stuff, all the water. If you ever work out the med tent for the Disney runs, the people who run when they shouldn't be running these marathons always run when it's like really, really hot out. They start sweating like crazy, and all they do is drink water. That's all they do is drink water. They don't drink Gatorade or Powerade, which has electrolytes, amongst other crap, but that's one of the reasons for it. So they just drink water all the time. Well, they're sweating, so they're losing volume, and they're losing sweat and salt from the sweat. And all they're doing is replacing with water. So their sodium levels drop. And if it drops way too much, like in the 110s, 1-teens, and those ranges, you can start getting seizures and comas by having your sodium level drop that much. These patients, you can't just give them salt. You got to restrict their water. Don't give them any water, and the salt won't go back to normal. But just know that you can have too much of ADH, you can have too little of it as well. So concentrating or diluting the water of the urine. So keep in mind again, especially in this section, the body doesn't care what the urine composition is. All it cares about is maintaining the ECF. So if we have an increased plasma osmolarity, what is our normal plasma osmolarity? Around, anyone know what the normal number is? It's around 280. 280 milliosmoles is like a normal, 280 to 320, that's like a normal range for an osmolarity for your blood. So if we increase the osmolarity of our plasma, we're adding a lot of solutes, so the osmolarity goes up. So the excretion of urine is more concentrated than plasma. What are we trying to do here? Where's the water got to go? Back into the bloodstream, right? Into the plasma. We don't want to pee it out. We got to reabsorb it. So some solute-free water is returned to the ECF, and your plasma osmolarity is back to normal. Everyone get that? Our plasma osmolarity went up, so we took all that free water from the urine, brought it back into the plasma to bring our osmolarity back down of the plasma. So when you're studying this, make sure you know, is this plasma osmolarity or urine osmolarity? The plasma osmolarity is what matters. We measure the urine as a marker to see what's going on inside the body. For example, if I check your urine and I see glucose in your urine, that already I can tell you're a diabetic probably, and your sugars have been averaging over 200 because the urine tells me that's what's going on. If I decrease plasma osmolarity, now I'm fluid overloaded. I got too much water in my blood, in the plasma. I'm diluting out all the solutes. So in this case, the urine is going to be more dilute than the plasma because I'm dumping all this excess water into the urine. So the urine will get lighter and lighter in color. Solute-free water is excreted in the urine and the plasma osmolarity increases. Whether the kidney produces concentrated or dilute urine depends solely on ADH, antidiuretic hormone. So let's do this one and we'll see how this water moves. What percentage of our body is pretty much water? About 70%. Okay, 70% water, and the rest of it is just whatever. Now, let's talk about water deprivation. If we are deprived of water, what happens to the water concentration in the body? It's going to increase or decrease from 70? Decrease. Let's say we're down to like 40%. Okay, so obviously we are very decreased. So what does that do to our solutes in this case? The solute concentration, does it go up or down? So we increase our solutes, and what is that going to do to our osmolarity? Increase the osmolarity of the plasma. Okay, water deprivation. We reduce the amount of water that we have. Okay, this decrease in osmolarity is sensed by the hypothalamus. Remember, the hypothalamus senses the concentration in the blood. It's got part of those organs that are circumferential organs that can get outside the blood-brain barrier. So this is one of the things that it has to look for, osmolarity of the blood. So the hypothalamus does two things. If we are very dehydrated, what does our body tell us to do? Drink more water, so it increases thirst. Okay? So we drink more. It's also going to release ADH, which is going to have its effect where? Where does ADH work? Common collecting duct, right at the end there. Late distal tubule, common collecting duct, whatever you want to call it. That's where the ADH is going to go. And what is the ADH going to cause this to do? Increase the reabsorption of what kind of water? Solute-free water. Okay. Increase sodium reabsorption. So, when we finally get down to the urine and we get out, we pee, and we're going to measure the urine. This type of urine, is it going to be diluted or concentrated? What's going to happen to our urine volume? Why is urine volume going down? Water's leaving. It's going back into the plasma. And what's going to happen to the osmolarity of the urine? Going to be high. So that's what happens when we are water deprived. ADH gets released from the posterior pituitary due to the stimulation from the hypothalamus. ADH will go to the cortical collecting duct and provide increased free water solute reabsorption. Therefore, the urine concentration is going to go up. Osmolarity goes up, but the urine volume goes down because we're pulling the water back. Make sense? That's why it's so important to check urine output when you're seeing patients. You want to make sure those kidneys are working well and they're still filtering enough blood. Now let's go to water excess. Now we have too much water. Let's say we're up here. And let's say we're at like 85% water concentration. So in this case, what's going to happen to the solutes in this case when we have water excess? Okay, and what's going to happen to the osmolarity in this case? Since our solutes went down, osmolarity will also decrease as well. We have way too much water, it dilutes out all the solutes, and they all drop. Therefore, our osmolarity also drops. Now, because we are now fluid overloaded, there really is no impulse going to the hypothalamus because we have too much. Do we need a thirst drive for this? Nope, so there's no thirst because we don't want to bring in any more water. We already have too much water as it is. Why add more water from drinking water? You don't need it. Is there going to be any release of ADH for these patients? Nope. Put a narrow line there, so no ADH, no thirst drive, no ADH being secreted. So now we get to the kidney, the nephron. Nothing's going to happen to the urine that forms in here and it goes down because there's no ADH release. Nothing is affecting these things. So nothing is pulling the water back into the bloodstream. So where's all the water going to stay? In the urine. What's going to happen to the volume of your urine in this patient? What's going to happen to the osmolarity of this urine? Decrease. There's less solutes. So that's what happens in the body when you have water excess. That's how you get rid of water. We can't have ADH going crazy. You'll never be able to diurese yourself. You'll fill up with fluid and go crazy. So ADH, we need it when we're water deprived. We don't need it when we have water excess. Okay? Any questions about ADH? So again, too much ADH, what happens? Too little ADH, what happens? Diabetes insipidus. So we mentioned before the SIADH, the syndrome of inappropriate ADH secretion and too high. When you have too little ADH secretion, it's called diabetes insipidus. And patients with diabetes insipidus lack proper control of renal water flux by the ADH. Don't worry about the rest of it. Just know that diabetes insipidus is the example when you have too little. SIADH, you have too much. Don't worry about that. Okay, regulation of our extracellular fluid volume. Long-term BP control requires maintenance of a normal ECF by the renal system. So our blood volume is controlled by our renal system. ECF is a function of the total amount of sodium in the extracellular fluid. Therefore, any disorder of extracellular fluid balance reflects difficulties with sodium. So fluid overload, people have salt, that's why I have a lot of salt restriction diets, so you don't have these issues. And obviously anything dealing with sodium abnormalities is going to have issues with water as well. So what does our body do? We're going to go over this one first. This is just describing what we're going to talk about now. So let's start at the top. low effective circulating volume. So our blood volume is very, very, very low. How does our body adjust when that happens? There's three things that happen. One, juxtaglomerular apparatus. That's going to sense the low volume of blood. It's going to secrete renin in this case. Renin will activate this whole RAS system, this whole RAS cascade. And the end result of that, renal sodium and water retention. If I retain sodium and water, what happens to my blood volume? Increases. That's one way our body is going to handle low volume. The renin-angiotensin system will also cause some vasoconstriction, which will also raise our blood pressure. The next thing that happens, these low pressure baroreceptors, they're going to sense, hey, we don't have enough volume in our system. We're not being activated. These low pressure systems, due to low volume of water, start getting activated. So what does that do? Increase ADH secretion. What is that going to do to your blood volume? Increase it. So indirectly with sodium and water, ADH we know also causes vasoconstriction, the V1 receptor. So that's going to also raise our blood pressure up. And the last one are these high pressure baroreceptors. Okay, they are not being stimulated. So therefore they know, hey, we have low pressure because we're not being stimulated. We don't have enough volume, no pressure. So what do those do? Also ADH secretion, but the big one is here, sympathetic nervous system. It's going to kick in, cause vasoconstriction, upping your pressure, and it's also going to excite the cardiac system, so the heart rate goes up and the pressure goes up as well, the contractility. So that brings your pressure up from there. This is how your body handles low effective circulating volume. We have to get our pressure back up again. If we don't, our pressure drops. If our pressure drops, there's not enough mean arterial pressure mapped to perfuse your brain or your kidneys, and you start getting problems. So it's very important that we remedy these low effective circulating volumes as fast as possible. So when you're studying this graph, it's a great one to study. Know, okay, what the three things are that are going to sense these effective circulating volumes, and then what are they going to do in response to it. The end goal is to increase your blood volume, to increase your pressure. Now, what do we do when it comes to high circulating volume? And this, again, all those words just describe what we're talking about in this graph. If we have high circulating volume, kind of nothing's going to happen because we don't want high circulating volume. But what does kick in is this right here. Increased atrial natriuretic peptide, ANP. And we'll talk about that in a second. I think I have a slide about that. Yeah, I do. Okay. So, juxtaglomerular apparatus. Is that going to worry about high volume or just low? Only low. So the high, nothing's going to happen. No renin out because it doesn't need it. Low pressure baroreceptors are going to be like, hey, there's too much pressure going on. We want the pressure to be lower. So it releases atrial natriuretic peptide. Atrial, because it comes from the atria. Natriuretic also sounds like diuretic, right? And the reason why they sound so familiar is that natriuresis or diuresis, if you see natriuresis anywhere, it's because sodium is moving that's causing the diuresis to occur. In the diuretics that we give, the loop diuretics, the thiazide diuretic, they block the chloride channel so that nothing works. Sodium is not moving in that case, really. In this case, with natriuresis, it's the sodium that's moving into the urine. What's it going to pull with it? Water. So that's a natural way for natriuresis to occur with the atrial natriuretic peptide. So it decreases the retention of the sodium in water. So we pee more of it out. High pressure baroreceptors, again, don't do anything because they're not being stimulated at this point. They're just going to, again, no major effects. All the effects really happen on the low side. So BNP is what a lot of you probably have heard of already. BNP is because at first it was only found in the brain. They didn't know the ventricles secreted it as well. So it was always brain natriuretic peptide, but we also measure it as a marker of fluid overload in the heart. Because the ventricles, as they get overloaded and stretched, they will release BNP because they're overloaded. They're stretched out too much. The body's trying to diurese itself naturally. And when it can't do it, then you get overloaded. You got to go to the hospital. You have problems breathing, all that other stuff. So BNP we look at as a marker of fluid overload, mainly in heart failure. We give a drug called Natricor. It's a form of BNP, so we give it to them, and it helps diurese them fast, naturally. Magnesium homeostasis. How does magnesium work? Magnesium is a cofactor in many enzymatic reactions. Plasma magnesium is intestinal uptake and urinary excretion. So what you get from your food versus what you excrete. That's how we get magnesium. Majority of reabsorption is in the thick ascending limb and the distal tubule. This last bit is important. Loop diuretics also cause loss of magnesium and calcium. Magnesium and calcium are very closely related. They're both 2+ ions. They act the same. They kind of go along together. Obviously, magnesium doesn't do a lot what calcium does as far as contraction and exocytosis, but magnesium is also involved in a lot of these enzymatic reactions, so we obviously need to have magnesium in our body. That's all you got to know for magnesium. That's it. Simple. Renal urea handling. So the end product of nitrogen metabolism is a water-soluble chemical. We look at plasma urea concentration, or BUN. The range is between 8 to 25 milligrams per deciliter is our normal BUN. Urea excretion depends on urine flow rate. So during antidiuresis, the water reabsorption concentrates the urea in the lumen, creating a diffusion gradient for urea reabsorption. So what is that telling us? Increased BUN with increased ADH. Therefore, BUN is a marker of dehydration. If you're looking at the BUN and creatinine, and the BUN is very high, but the creatinine is normal, that patient is just dehydrated, give them some fluids. Their kidneys are fine. So if the BUN goes up by itself, their patient is just dehydrated, give them some fluids, and they're okay. So when BUN is elevated without increasing creatinine, they're reabsorbing water to stave off dehydration. So that's where BUN comes into play when it comes to the kidney function. That's it on BUN. Calcium. Under the influence of parathyroid hormone and vitamin D are the two big things that alter calcium balance in the blood. It exists in three forms. 45% is free ionized calcium, just floating around the plasma as calcium by itself. 45% is bound to plasma proteins. So when anything is bound to a protein, think of it as being inactive. It's not working anymore. So if it's bound to a protein, it's not really active. It's not doing anything. So this calcium doesn't really do much for us. And 10% is made with low molecular weight anions like citrate and oxalate. When you get those two things forming, what do you get? Kidney stones. Okay, calcium is one of the big things that causes kidney stones. When you get really dehydrated, the calcium can precipitate out into a crystal form as calcium oxalate or citrate, and that gives you like kidney stones. So the filtered load is a product of GFR and the free plasma concentration. So only the free plasma, 45% of your plasma concentration, actually gets filtered because 45% is bound to a protein. Do proteins get filtered? Nope. So that's why that doesn't include. Occurs in the thick ascending limb and the distal tubule. And this is an important one down here as well. PTH, vitamin D, and your thiazide diuretics. We mentioned that before with magnesium. Stimulate calcium reabsorption in the distal tubule. If I'm reabsorbing calcium from the distal tubule, where is it going? Back to the blood, back to the plasma. So I keep my calcium levels up. Do you see now why vitamin D is so important in keeping your calcium levels normal? Because without vitamin D, you're not going to reabsorb the calcium out of the kidneys. You're going to lose a lot of calcium that way as well. So that's why you need vitamin D there as well. This one is just talking about urinary calculi. We already talked about that. Renal phosphate. Okay, so inorganic phosphate is influenced by intestinal uptake. What do we eat? What do we excrete? And finally, with phosphate, exchanges with the bone. Calcium and phosphate are the two big things that make up our bone. When bone starts to degrade, you get calcium coming out, phosphate as well when you break down bone. Phosphate is in our blood as two major forms. First one is 80% of it is alk phos, and 20% is acid phosphate. The phosphate is what's excreted in the urine. Reabsorption is restricted to sodium, this co-transport, but only in the proximal tubule. Don't worry about the whole co-transport, but know where it happens. Proximal tubule, very dependent on GFR. So one of the early signs of renal insufficiency is your plasma phosphate increases because your kidneys can't handle it anymore. So it starts to build up. And PTH is a very important regulator, which we'll get to a lot more in endocrine. Where are we at? Okay. Let me see where we're at for slides number. Okay, the rest of it we can finish on Thursday. So we are done. Remember tomorrow, guys, for anatomy lab, what group is going at 8? A. Group B is at 10. Same procedure as last time. What's the structure?